Hello friends, hope you are all okay. You are enjoying your life, you are enjoying practicing ultrasounds as well. So with respect to a different cyst and their surveillance scan, their follow-up scan, and what next modality and what are the differential, this video will be all about that. So I will discuss about the liver cysts. What would be the pattern of to carry this scan as a follow-up scan or as a surveillance scan, or what would be the next modality, what we will advise on the report for the next, and what would be the differential, logical differential. And after that I will also discuss about the adnexal cyst. If these are simple, so what would be the next modality, what would be the next pattern. If it is complex cyst, so what we will advise on the report, how we will pursue that, how we will look for the surveillance scan, where we will advise the next modality, where we will advise the referral. So we will discuss about these two cysts in today's lecture, in today's video. Liver cysts. Liver cysts could be simple or liver cysts could be complex. So I'm talking today about the simple and complex cysts, not any malignant cysts. So today, simple cysts, if you come across any simple cyst of the liver, the normal pattern, radiological BMUS guideline is that you ask for the follow-up scan, and that follow-up scan should have been in within 6 months. So review the patient, ask the patient to come back after 6 months, look if the size is okay, it's not significantly enlarged, so you can put another follow-up scan after 1 year. So that is the protocol, we can follow that, and this is normally acceptable practice. But if you come across any septated cyst or any wall calcification or any internal low level echos which give rise to any suspicious differentials, so for that you have the two options available with you. The first best option is, if there is low level echos and you suspect this could be hemorrhagic cyst, or this could be abscess, or this could be high dilated cyst, so the best method is to advise post therapy follow-up scan, because by the time when you receive this patient, he might not have taken any medicine. So this is best to advise post therapy scan. So just leave it to your colleague, whatever the medicine he is going to give it to according to the symptom and other investigations, he will take his medication, and then again this would be referred to you within the time frame of 6 to 4 weeks, and you rescan that patient. And if you notice that the regression is going on, so put on your report that compared to the previous report the regression has taken place. So I think there will be either need a follow-up scan after 4 weeks, whatever you think that it would take to regress, or you can see there is no need for the follow-up scan. So this would be the second protocol for the complex cyst. And the third one is, if the complex cyst you come across which give rise to any suspicious findings, so you can straight away mention that further radiological imaging are considered or recommended. Here I would like to clarify one thing. Many of colleagues, they write down higher imaging. I can't get my head around that, what does it higher imaging is concerned. So for the higher imaging is related with respect to higher imaging, straight away one point jump into my mind, higher education. So I think the best method is to write down the best further radiological imaging. If you know specific one, mention the specific one. If not, so just mention that further radiological imaging should be considered. The best method of writing the radiological imaging, if you come across any cystic lesion which you think it could be suspicious, whether sometime there might be a cystic metastatic deposit, so in that condition you can advise the best is triphasic ultrasound, triphasic CT scan. So triphasic CT is the modality in which you are looking for the washout and the retain of these contrast. So as a result, there are certain diseases, certain lesion which would be identified as a malignant or benign. So this is the first modality you can advise, triphasic CT abdomen. If not, you can also advise contrast enhanced CT scan. So if there is any contrast within it, so it means it's vascular, or the differential will further goes on. But if not, so it will clarify this is the cystic lesion. The third thing is MRI for the soft tissue. If you think there are some soft tissue components, so the MRI would be the best modality. And after you have to go through the histopathology to take the biopsy and find out what the histopathology says, whether it's been composed of benign cell or malignant cell. So this is what all the procedure is. So if there is simple cyst surveillance scan, 6 months, after 6 months, if the size remains same, annual surveillance, and after annual surveillance, if again remain the same, so just after 2 or 3 years, just have another follow-up scan. If it is complex cyst, for the complex cyst, advise post-therapy ultrasound. After post-therapy, if the cyst regressed, well and good, just keeping that process in view. If it is gonna regress half of the cyst within 4 weeks, so advise further 4 weeks scan to look for the further complete resolution. And if not, so then you better advise further radiological imaging. This could be triphasic CT scan, contrast enhanced CT, MRI, or correlate with the histopathological finding. So that is further their responsibility to go further for that. So this was the protocol for the liver cyst, their follow-up scan, their surveillance scan, and their what next modality. The one another thing is there are certain benign lesions like hemangioma. These type of hemangioma, you have to have a surveillance scan, further surveillance scan after 6 months. Advise surveillance scan because you have to keep eye on whether this hemangioma is gonna bigger or not, because there would be a chance of hemorrhage. So therefore keep eye on that. After 6 months, if the size remains same and it is within sub-centimeter or a few centimeter or less than 2 centimeter, so keep going after 6 months. But if it is getting enlarged, so then further imaging should be requested, or you can advise follow-up scan of every 1 year or annual follow-up scan. So I think this would be the best modality to look for all that. In case of any high dilated cyst which is calcified and no more further regression, so 6 month follow-up, after that surveillance scan after 6 months and after 1 year, just to keep eye on whether there is some other pathological processes surrounding that area has been initiated or not. So this was all about the liver cysts. With respect to adnexal cysts are quite common. Every now and then you will come across with adnexal cysts. This could have been simple, this could have been complex. So if there are or if there is simple cyst in the adnexal region, advise 4 to 6 weeks follow-up straight away. But mind you, as I have mentioned, that you should know about whether it is mature follicle or it is development follicle or it is truly cyst. So please, if you have if you're not aware of that, go back to my videos and find out that I have mentioned the different sizes of that. So please follow that protocol. I'm talking in respect of more than 3 centimeter, which is considered to be a cyst, frankly cyst. So if it is the size is remain from 3 to 5 centimeter, advise follow-up scan after 4 to 6 weeks. Within 4 to 6 weeks, with the next menstrual period, usually we have seen that 80% cysts regressed. So then there will be no further follow-up scan, because you would see that the cyst has been gone down. If not, so again the same protocol, advise post-therapy follow-up scan. So after post-therapy, the patient will take the medicine, either antibiotic, anti-inflammatory, or whatever their protocols are, because we are radiologists and we do not know about the medication process as much as the other gynae colleagues or other general physicians or GP knows about that. So therefore just leave their topic, do not put your feet into the other boots, let them doing their own job. So advise post-therapy scan, and then look for the follow-up. If the cyst has gone down, so mean that it has regressed, no follow-up scan. If has regressed half of the cyst, So again, follow-up scan for 4 weeks, so look for the complete resolution. And if you think there is suspicious phenomena, maybe cystadenoma or cystadenocarcinoma or some other suspicious list, teratoma or dermoid or whatever, there is a vast differential, you know about all that. So if you suspect that, so advise further radiological imaging, not higher imaging please, further radiological imaging. So radiological imaging should have been again contrast enhanced CT, CT triphasic. MRI is the best because that is the area where MR working very well, and then histopathology is the best modality to look forward for that. So this is what the protocol for the adnexal cyst if you come across. So I think this is a straightaway line, so just try avoid confusing. Do not confuse the patient, do not confuse your colleague, because of the law they are bound by whatever you have written on the report, so they will definitely follow up that. So instead of just giving confusion, make your mind clear. This is what the condition is, this is what your outcome is, this is what you suspect, and this is what we have to follow it up. So through that procedure you can advise follow-up scan, you can advise surveillance scan, you can advise what further, what next modality would be, and then this was all about. So I have collected some of the images regarding all these liver simple and complex cyst. I will just narrate because you already know how the complex cyst and how the simple cyst will look on the ultrasound imaging. So for the next is concerned, you still know very well, so I'm not gonna complicate this video. This is just simple short video to make you understand that what we will follow in case of surveillance, follow-up scan, what next modality, and where we have to ask the patient to go for the referral. So this is what all this video is about. So let's start watching these images.
Look at this image. This is a liver, and in the liver, within the liver parenchyma, there are multiple cysts. The largest cyst should be less than 2 centimeter in size, but internally there is no echo. It's all simple set. But keeping in view that there are multiple cysts, always look for the kidney, because in von Hippel-Lindau disease, there is likely possibility you may have multiple cysts in other organs of the body as well. But if in case there is no other cyst in other organs and it's only the liver cyst, so the best protocol for that is to scan the patients within 6 months. So after 6 month follow-up scan, if the sizes of the cysts remain the same, so then you can further look for the surveillance scan after 1 year. So this is what the normal procedure is. But if in case the patient giving some history of cancer or anything, always look for the higher imaging, higher radiological imaging to confirm whether these are cystic metastasis or not. But that would be in case when the patient gives you the history of cancer or the patient is senile. Otherwise, if patient is young, within 30, 40 or 50, and you come across these cysts, these are happens to be primary cysts, so the best protocol is follow up after 6 months, and if the sizes remain same, you give a surveillance, you advise surveillance scan after 1 year. The best description for this cystic lesion would be simple cyst. As you can see, this is within the liver parenchyma, right lobe of the liver, and attenuation can also be visible. This black arrow showing simple cyst. Again, this cyst is normal cyst and it is single cyst, and there is no other complication within the cyst, no low level echoes, no wall irregularity, and it is diagnosed for the first time. So the best is that ask the patient for the rescan after 6 months. So within 6 months, if the size remains same, you can again follow up after 1 year, keep the patient on surveillance scan, and this would be the protocol. Again, I would mention here, look for the patient age and the previous history. Is there any sinister findings, like if there is possibility of cancer? So the one possibility is cystic metastatic, but as this cyst is very round, very clear, and it look like a primary cyst. So for the primary cyst within the liver, and if it is singular, so the best protocol is follow-up scan after 6 months, and if the size remain unchanged, there is no significant increase or enlargement in the size of the cyst, or there is no other intra cystic contents or hemorrhage or calcification, so advise the patient for the follow-up scan after 1 year. So surveillance scan could be after 1 year. So this is the normal protocol, first 6 months, and then after that it is best to advise annual surveillance scan. On this transvaginal scan, you can see simple adnexal cyst. It is well defined, no irregular wall, no internal contents is visible. So in short, this explained as a simple adnexal cyst. And if the size of the cyst is less than 3 centimeter, so you can rescan that patient within 4 to 6 weeks, and usually this disappears. If the size still remain in between 4 to 5 centimeter, still you can follow up the scan within 4 to 6 weeks. But in case the size is increasing more than 5 centimeter, then the proper protocol is write down the referral for the gynecology and forward this to the gynae team. Then they will decide whether there is any other need for the follow-up scan, or they want to put the patient on medication, and then again after medication they are looking for the follow-up scan. So this is entirely up to them. But so far radiological imaging is concerned, if the size remain less than 5 centimeter, still you can advise follow-up scan within 4 to 6 weeks. After 4 to 6 weeks, if the size regress, well and good. If not, and it remain the same, you can refer the patient to the gynecology. Or in case if the size of the cyst is increased than the previous size, so again it would be better to refer the patient to the gynecology colleagues, so they will further decide what to do with this next, either medication or follow-up. Radiologically speaking, this cyst would be considered as complex cyst, and in the complex entity this would be called as hemorrhagic cyst. You can see low level internal echoes floating within the lumen of the cyst. Beside this, you can also see some thick septa or debris, you can call that as debris as well. So far the wall is concerned, wall is not thick. This slightly thickened particles and debris can be seen within it, which could be likely fibrinous tissues. So this what explain is hemorrhagic cyst. For the hemorrhagic cyst, best protocol is that you refer this case for the higher imaging as well, for the higher radiological imaging, to find out whether this is a chocolate cyst or this is some other entity. So they will further explain it. But so far radiologically imaging is concerned, or ultrasound is concerned, here on the ultrasound you can only differentiate whether this is simple cyst or this is complex. In case of any complexity, the first possibility is that you ask patient for the follow-up scan within 4 to 6 weeks post therapy follow-up scan. So the patient would take the medicine, again she will be sent back to you, and just look for if the cyst is regressing, that is okay, you can give a follow-up scan after 4 weeks, again 4 weeks, to look for the complete resolution. If the size is not regressing and it still remains the same after medication, so the next protocol would be advise further radiological imaging. And further radiological imaging includes MRI. MRI best explains the soft tissue within the pelvic region. So any problem related to the soft tissue, the MRI is the best imaging modality which explains everything. So therefore, if you come across certain hemorrhagic cyst or any complex cyst and your suspicion is towards the endometrioma or chocolate cyst or dermoid cyst or cystadenoma or cystadenocarcinoma, so these are likely differential or likely possibilities. So advise MRI scan, because MRI scan will explain all these things in beautiful way. So this is what the hemorrhagic cyst example. This is transvaginal scan, and on this scan you can see a complex cystic lesion which is called as dermoid cyst. Wall of the cyst is smooth, regular, but within the cystic parenchyma you can see low level internal echoes and thin septation as well. Beside this there is an echogenic nodule. So this is actually the dermoid cyst. But what's the normal protocol is you have to put the Doppler signal on it and look for vascularity within the dermoid nodule. If there is dermoid nodular vascularity, it gives rise to suspicion of malignant potential. So therefore always put the Doppler when you come across with any intramural nodule. So this is what dermoid cyst is. Now what would be the protocol for that cyst? The protocol is you advise the patient to have MRI. For dermoid cyst, if it is enlarged enough, if it is more than 4 centimeter or 5 centimeter, it is best strategy to refer the patient for the gynae department. If you are sure that on the ultrasonic imaging it is dermoid cyst, refer the patient to the gynae department, and also advise further higher radiological imaging for the confirmation of the diagnosis. So this is the protocol for the dermoid cyst. In the dermoid cyst, there is no need for any follow-up scan because it needs proper correction, it needs proper surgery or whatever the gynae colleague suggests they have to go through this process. So do not advise a follow-up scan for the dermoid cyst if it is quite clear. If you give it as a differential that your likely possibility there is likely possibility of dermoid cyst, then you can advise follow-up scan after 4 to 6 weeks. And if the size and the contents remain the same and there is no regression and there is sometime enlargement in the dermoid cyst, so then you can follow the same procedure. Advise the MRI scan, advise the patient to consult the gynae department. On this transvaginal scan, a comparison has been given. Look towards the left side complex cystic lesion. There is hair-like thin linear shadows within the lumen of the cyst. So this could be small hair or hair structures, which is again dermoid cyst. In the dermoid cyst, there may be tooth, there may be hair follicle, there may be nails. As you know, these are all skin derivatives. So any of the skin derivatives, if appears within the lumen of the cyst, so that would be considered as dermoid cyst. So on the left side, this is the typical appearance of the dermoid cyst, but on the right side there is another dermoid cyst, which you can see an echogenic in a nodule within the cystic lesion, and this is again a dermoid cyst. So these both are dermoid cysts. There is no need for any follow-up scan. Straight away advise the patient for further radiological imaging, MRI, because MRI will pick all these 2 points, these small hair follicles, or this could be tooth or any nail particle, as these are all the skin derivatives. So therefore the MRI scan is the pertinent radiological modalities for this dermoid cyst, and after that refer the patient for the gynae department for further proper management.